Hospital in London, which is shown here. And my talk is going to focus, my talk is going to focus on MRD-guided therapy in AML. And, Great, thanks so much. So I'm going to try and address two questions during this talk. The first of which is, can and should we use sequential MRD monitoring for relapse surveillance and preemptively treat this? And the second is, can we use MRD measurement to select patients to be transplanted in first remission? And I'm just starting with a provocative statement that I saw actually at one of the oncology conferences. This was from a solid tumor oncologist. And their vision of the future was the future of oncology needs to be measurement of minuscule disease burden to guide serial preemptive therapy to prevent relapse. This is the solid tumor oncologist's vision of the future, but of course, as hematologists, we have been doing this for more than 20 years, thanks to the pioneering work of Francesco Lococo and David Grimwade in APL, who showed that we can use sensitive molecular diagnostics to reliably identify those patients who were going to relapse before they did so, and give them preemptive treatment to prevent the relapse, which would improve their outcomes. And actually, by coupling these diagnostic techniques with preemptive intervention with targeted therapy in the form of arsenic trioxide, proved very powerful. And actually, this practice has almost completely eliminated frank relapse in APL to the extent that we very rarely see this now. This monitoring and preemptive intervention also made the first frontline arsenic trials possible, and perhaps somewhat ironically has led to the really the retirement of molecular monitoring in APL now due to the extreme efficacy of these treatments. So can we and should we use a similar approach in other types of AML? So what would be the advantage of treating a patient with MRD relapse where the disease burden may be perhaps 0.001% of blasts, compared to frank relapse when the patient may have 50 or 100% of blasts? Well, you can think of several theoretical advantages. First of all, this provides a lot greater lead time in order for you to act, so you don't need to make the patient be admitted to hospital right away and start the salvage chemotherapy tomorrow. There's time to act, which may be important, because of course transplantation or other cellular therapy is a critical part of these patients' treatment, and this takes time to plan. Secondly, the patients present with normal full blood counts, which means they're much less likely to have active infections. They're much more likely to be clinically well. And that theoretically means that we could deliver salvage therapy as an outpatient. Because of the lower disease burden, perhaps they may need less salvage treatment. And because of the low starting disease burden, and the fact that the patient starts with normal blood counts, perhaps the salvage treatment may be less toxic, with less chance of getting serious infection or other complication, which may make transplantation impossible. And finally, the low disease burden salvage treatments might be more effective. Targeted treatments might be more effective because there's statistically less chance for clonal evolution and escape to occur. And immunotherapies such as DLI or bispecific antibodies may be more effective because the effective to target ratio is significantly more favorable. So I'd like to talk you through some evidence about whether this is feasible and actually whether this does improve outcomes. So first of all, we know from this really nice study that was performed by the FILO group and published recently that this approach is feasible for patients with NPM and core binding factor leukemias. So in this study, they showed that probably 2/3 of relapses could be detected at the MRD stage where the patient was in morphological remission. And there were much fewer deaths after molecular relapse than after morphologic relapse. Important point. Substantial proportion of patients progressed from molecular to frank relapse before they could receive treatment. You can see that the outcomes for patients who were treated at MRD relapse, which is in the blue line, were significantly more favorable than either those that were treated at morphological relapse or that group of patients that was diagnosed with MRD relapse and then progressed. So this is very interesting data and shows the feasibility of the approach, but unfortunately it cannot answer the question of whether this approach improves outcomes because there's a significant selection bias here. Likely those patients that were able to be treated at the time of MRD relapse had significantly less aggressive disease biology. And perhaps this is supported by the fact that there's no difference in outcomes for those patients that had morphological then frank relapse. So in the UK group, we've tried to answer the question of whether this actually provides clinical benefit to patients by performing a randomized study. And in this study, we randomized patients between having sequential MRD monitoring or standard care with just routine full blood count assessment. And we performed this across our AML 17 and AML 19 trial protocols. And overall, so we screened all patients for molecular markers using cytogenetics, PCR, and RNA sequencing. And we identified markers in approximately 1/2 of the patients. And we randomized 625 patients to either have, in a 2-to-1 ratio, either to have no monitoring, either by flow or molecular methods. It was simply to have routine clinical follow-up, or sequential MRD monitoring after each course of the chemotherapy, and then every 3 months for at least 3 years after treatment had been done. So these are the molecular markers that were identified in this study. You can see that the most popular one was MPM, as expected. And this was divided for the purpose of the analysis into patients with and without FLT3 ITD. There was also, as expected, a significant proportion of patients called binding factor leukemias. And unlike the FILO study, we've also monitored patients with KMT2A and other rare fusion transcripts. So first of all, does this approach reduce the rate of relapse? So, of course, this depends on the definition of relapse. If we use the traditional definition of morphological relapse with the emergence of more than 5% blasts, you can see, yes, indeed, the rate of hematological relapse is reduced. But if we include MRD relapse in that definition, you can see the overall rate of any relapse is not reduced, but the relapses are diagnosed significantly earlier. So does any of this improve patient outcome? Somewhat to our disappointment, we found that there was no overall survival benefit for patients randomized to monitoring, but there seemed to be significant heterogeneity between the molecular subgroups, and we did think we saw a significant benefit in this molecular subgroup defined by the presence of both NPM1 and FLT3 ITD mutation. And the survival curve for those patients is shown here, and you can see there's a significant improvement in overall survival for those patients who had sequential monitoring. And the hazard ratio is about 0.5, and this was consistent between the two trial protocols. One of the reasons we thought that the patients did not benefit from monitoring as much as we thought they would was that all of the patients who were treated for MRD relapse actually received the exact same treatment, salvage chemotherapy, as patients with frank hematological relapse, because at the time when this study was done, there was no access to targeted therapeutic approaches for MRD relapse. So what kind of targeted therapies could we consider in this situation, analogous to arsenic and APL? So to date, there are very few, there's only one prospective study actually so far reported in this setting, and this is the VALDAC study of venetoclax and low-dose cytarabine. It's a single-arm study performed by Ing Soo Tiong in Melbourne, Australia. And in this study, he recruited patients with either MRD relapse or patients with what they called oligoblastic relapse, which were with between 5 and 15% of blasts, were also allowed to enter this study. And interesting, similar to the FILO study experience, quite a number of patients started with MRD relapse, but before they could be treated, they had progressed to oligoblastic relapse, so they were still allowed to be treated. And remarkably, you can see that the response rates with this treatment actually, with over half of patients going MRD negative and overall about 75% of patients having some kind of response, are very similar to what we saw in our monitor study with intensive salvage chemotherapy approaches, but clearly with much less toxicity and being able to deliver this therapy as an outpatient. The overall survival for these patients was rather impressive with 63% survival at 2 years. And particular benefit was noted for patients with NPM1 mutation, MRD relapse in this cohort. And we went on to look at this. This is now, unfortunately, all the other data in this setting are retrospective case series. So we performed this multi-center European study looking at patients with NPM1 MRD relapse who were treated with venetoclax and low-dose cytarabine or azacitidine combinations, specifically for patients with NPM1 MRD relapse. You can see that their response rate, overall MRD negativity, is 71%, but this is very this is very different according to the FLT3 ITD mutation status at baseline. With patients who had a FLT3 ITD mutation, only 50% of them achieving MRD negativity, compared to almost 80% in patients who are wild type. And this is reflected in the overall survival difference between these two groups, as you can see. Interestingly, but probably this data is rather unreliable, but we did not actually see any difference between those patients that were bridged to transplant and those patients that just carried on with the venetoclax low-dose salvage treatment. Second treatment has been tried, again, and this is in the retrospective data, are different FLT3 inhibitors. And you can see again that we can get pretty good response rates with single-agent FLT3 inhibitors in this setting. Overall, in this, again, retrospective study of 56 patients who were treated with FLT3 inhibitors for MRD relapse, the overall response rate was 65%, going up to 75% in patients who met the true ELN definition of MRD relapse. Important to point out, this study was done before the widespread availability of FLT3-directed NGS-based MRD testing. So all of these patients were monitored and diagnosed with MRD relapse based on either an NPM1 mutation or a fusion gene. So moving on to the second question, can we use MRD status to select patients who will benefit from bone marrow transplant in first remission, which is, of course, one of the age-old questions in AML. And in this section, I'm going to focus on NPM1 and then core binding factor leukemias, starting with NPM1. And we know from many cooperative group studies now that there is a major survival benefit from becoming MRD negative, with all studies reported so far showing a very, very significant difference when MRD status is measured after the first 1 or 2 courses of induction chemotherapy. And one of these studies looked in a retrospective, non-randomized fashion at the impact of transplant according to MRD status, and this is from the alpha group. And you can see from this figure that only patients who are MRD positive in the red and the grey lines have a significant benefit from transplant in this study, whereas patients who are MRD negative did not appear to benefit. So this has influenced many people to consider MRD status when deciding which patients to transplant in many centres. However, there's still rather a lot of unanswered questions. In particular, a question that very often comes up is whether co-mutations or other clinical features associated with worse survival should affect the decision, or whether this should be entirely based on MRD status. And this has led to a widespread variation in practice between centres and between countries. So we have tried to address this question, again, using our large NCRI trial protocols, the same 2 studies, which were AML 17 and AML 19. These were studies of younger patients, generally under the age of 60, receiving intensive induction chemotherapy. And altogether, across these 2 studies, we could identify 1,357 patients with NPM mutation, and of these, 737 had both MRD status measured in the blood after cycle 2, which in our hands is by far the most predictive time point for MRD assessment, and they had a full molecular profiling by NGS available. Importantly, there was a difference between the 2 studies. In the AML 17 study, the MRD status was not used to allocate transplant. This was entirely based on a risk score, which is calculated from baseline clinical and molecular risk factors. And in the AML 19 protocol, it's completely changed based on the emerging data from the previous study. And in the AML 19 study, we only used MRD status to assign patients to transplant. So this provides a kind of a good balance of patients who were selected for transplant based on clinical features or MRD status. And we tried to address the question of, does becoming MRD negative cancel baseline genetic or clinical risk factors? Or conversely, could we identify any MRD negative patients that had a benefit from transplant in first complete remission? We started by looking at clinical or molecular risk factors that were consistently associated with outcome in this large cohort, and unsurprisingly identified the usual clinical features that most studies have already identified as age, antecedent hematological disorder, and white blood cell count. And in terms of molecular risk factors, we identified FLT3 ITD and DNMT3A, both very well-described co-mutations which modulate outcome, and additionally WT1 as significant predictors of survival. But what was interesting was these same factors appeared to predict patients who would remain MRD positive. So therefore we wondered whether achievement of MRD negativity would cancel out the adverse effect of these co-mutations. Indeed, this appears to be the case for FLT3 ITD. So if you look on the left, this is a survival of patients who became MRD negative in the blood after the second induction, according to whether or not they had a FLT3 ITD at baseline. If you look on the right, this is the outcomes of patients who remained MRD positive, and you can see here the FLT3 ITD patients do much worse, extremely poorly, but amongst those who become MRD negative, there's no difference in their outcome. But what about the other mutations? And here the situation is somewhat more complex. So you probably are well aware that this combination of FLT3 ITD, DNMT3A, and NPM1 has been previously reported by several groups as being associated with poor survival, and indeed we could confirm this. The MRD status, to some extent, captured this. So only 63% of the triple mutated patients became MRD negative. But of those that became MRD negative, they still had a somewhat elevated relapse risk, about 40%, approaching the level where some may consider transplant to be indicated. A similar picture emerged, perhaps even more complex, with WT1 mutation. So what you can see on the left panel here is the prognostic impact of the WT1 depends on the other co-mutation which it occurs with. So the patients with NPM1 and WT1 alone are on the pink line, and they do the best of all. However, when WT1 occurs alongside DNMT3A or FLT3 ITD, they're on the blue line, and they do worst of all. And even for those patients who become MRD negative, their relapse risk is again somewhat elevated and is touching roughly on the 40% relapse incidence. What about the benefit of transplant in this group? And this is a non-randomized comparison. Overall, if we look in this entire cohort of 737 patients, you can see that those patients who were MRD positive in the blood after post-course 2 had a major benefit from transplant in first remission, and the hazard ratio for death is 0.39. On the other hand, we could see no survival benefit whatsoever for transplant in patients who became MRD negative by post-course 2. This holds true in patients with the baseline FLT3 ITD mutation, as shown here. And it holds true as far as we can see across all of the molecularly defined subgroups, including these patients with the triple hit genotype, DNMT3A, FLT3, NPM1, where you can see that there is no apparent benefit for CR1 transplant. And it also applies to those patients with WT1 and one or more of the other co-mutations, in which, again, we don't see a survival benefit for transplant. So as far as we can see, and this is being reflected now in our current protocols, is the MRD status is the only thing that should really be considered when making transplant decisions in this younger adult population. And finally, I'd just like to talk about the core binding factor leukemias. And in many ways, this is a similar situation where there's somewhat conflicting data about the relative importance of MRD status versus baseline molecular risk when deciding how to treat these patients. And in particular, FLT3 ITD and c-KIT mutations have been identified as associated with being poor outcome. Again, this French study provides very useful information on this. This is looking at MRD status at early time points post-course 2 in the bone marrow Interestingly, there's a significant increase in relapse for those patients that do not hit the 3-log reduction, but there is not really any impact on overall survival here. So this suggests that there perhaps isn't strong enough evidence to consider MRD at this time point as an indication for treatment intensification. How does the MRD status interact with the baseline molecular risk? Well, you can see in a multivariable analysis, actually the MRD reduction significantly outweighs the presence of the KIT or the FLT3 mutations. And actually, in all of these groups, the overall survival is rather good, with the exception of patients both with a failure to achieve 3-log reduction and with the presence of a KIT or FLT3 mutation, where actually they do actually pretty significantly worse, with a 3-year survival of 56%, although this is only based on 23 patients. This may be a group which would benefit from change in treatment, but so far there are no confirmatory data. How about MRD status at the end of treatment for these patients? Here you can see from the German AMLSG study, this was also confirmed in the French and the UK cohorts, that the MRD status at the end of treatment is associated both with relapse and with overall survival. But there's a significant caveat here, which is you can see that about half of patients are MRD positive at the end of treatment, and fewer than 40% of those relapse. So clearly, simply being MRD positive at the end of treatment is not an indication to change treatment. The different study groups have all defined thresholds above which we can reliably predict patients who are going to relapse. For example, this is the NCRI thresholds, which differ between blood and bone marrow, and in version 16 and 821. And we can reliably predict in our hands which patients are going to relapse based on the end of treatment levels. Unfortunately, so far, these levels do not correlate very well between the different cooperative groups. So this is our approach to the management of core binding factor leukemias utilizing MRD status. So far, we do not consider intensification of patients based on their post-course 2 MRD results, although I think there's a question mark over patients with failure to clear MRD and a coexisting FLT3 or KIT mutation. If the patient tests repeatedly positive above our predefined clinically validated thresholds at the end of treatment, we will consider intensification of treatment and transplant. And finally, we monitor all these patients closely with bone marrow MRD, looking for MRD relapse, and treat these patients preemptively. And we can achieve rather good results using this strategy. These are results from our most recent NCRI AML 19 protocol, in which patients treated with the DA-GO protocol had a 5-year survival of over 90%. What are the future directions might look like for this field? This is my speculations. Sorry about that, I'm going to not touch the microphone. So first of all, yeah. Don't worry, I've nearly finished. First of all, I think modern diagnostics will have a significant impact on the number of patients that we can identify with trackable molecular markers. And I'd like to highlight this study from the German BFM group. This is looking at the pediatric setting, but by applying an RNA sequencing panel, which I think is pretty much routine now in the pediatric AML, they approximately double the number of patients with fusion genes. A lot of these are cytogenetically cryptic, and so massively increases the number of patients that can be tracked by molecular approaches. In an adult setting, I think particularly KMT2A rearrangements are amenable to tracking by qPCR. And this is a figure from a paper that was just published earlier this week, which is a collaboration between us and the Australian group, showing that this has very powerful prognostic information in the pre-transplant setting. Obviously, this is maybe of great interest given that targeted menin inhibitors are now becoming available. Secondly, we desperately need more prospective data. More or less everything I've shown is retrospective. We need to have more prospective studies of targeted agents in MRD relapse. Unfortunately, a major problem to date has been a difficulty in interesting or even making them understand the drug industry about this particular situation. And thirdly, I'm not talking about this at all, but it's very exciting data emerging on the use of NGS for detection of FLT3 ITD mutations in the MRD setting. And I'm sure you're going to hear more about that from our next speaker, Mark Levis. So I won't say any more about that. I need to thank you very much for the invitation again, and thank you for your attention. And also thanks, obviously, to our team and funders and trial participants. Thank you.
Est-ce qu'il y a des questions? Sarah?